Today we're going to talk about the respiratory system. So with the respiratory system, we can divide it up a couple ways. One way is to divide it into upper and lower respiratory systems. The upper respiratory system is going to include the nose and the pharynx. The lower respiratory system will include the larynx, trachea, bronchi, and lungs. This designation is used a lot of times if you're talking about an upper or a lower respiratory infection to look at exactly where it is in the body. We can also divide it up into a conducting portion and a respiratory portion. The conduction portion is going to include the tubes. So this will be the nose, pharynx, larynx, trachea, and bronchi. The respiratory portion is going to be the lung tissue where you actually have the gas exchange occurring. So here over to the right, we do have an illustration of the respiratory system. And when you look at this, you can see that you have your nasal cavity is actually continuous with the oral cavity. So things can go from the mouth up into this cavity. We do know that it also connects through the eustachian tube into the ear area, and then you have the nasolacrimal duct that's going to provide a passageway into the eyes. So the respiratory system, if we're going to follow the pathway that air takes through, it begins at the nose. You've got the external nares, which are the nostrils. The internal nares are going to be the internal openings that are going to actually connect to the throat. In order to see these, you would actually have to remove the nose off the face. Your nasal cavity is inside the internal nose. So this is not the part that you can actually reach with your fingers into your nose, but it's if you were to take the nose off of your face and go through those holes that you see on the skull, the area above the mouth is going to be the nasal cavity. And then the nasal septum is going to divide the nasal cavity into right and left portions. Ideally, it should be divided into equal right and left portions, but that doesn't always happen for people. The pharynx is going to be the throat, and we divide this into three regions. So the nasopharynx is this upper portion of the pharynx. It's going to have the pharyngeal tonsils and eustachian tubes. The oropharynx is the middle pharynx. This is the part that you would generally consider your mouth. It will contain the palatine and lingual tonsils. And then the laryngopharynx is going to be the lower portion of the pharynx. This will connect to the esophagus and the trachea. So continuing on down the line, we have the larynx, which is your voice box. It's about at the level of C4 to C6. There's cartilages that are going to surround this. The thyroid cartilage is made up of hyaline cartilage. It's going to make up the anterior wall of the larynx. This is the one that will have the Adam's apple in males. It's really just some hypertrophy of the cartilage due to hormone differences. The epiglottis is elastic cartilage. This is going to cover the trachea. This is going to come down when you swallow to prevent food from going down into the airway. The cricoid cartilage is also made up of hyaline cartilage, and it's attached to the first ring of the trachea. And the arytenoid cartilage sits above the cricoid. This one's attached to the vocal cords and the pharyngeal muscle, so it does play a role with voice production. This picture here is showing one of the rings of the trachea. You can see that it's got hyaline cartilage that holds it open, and then it's going to have ciliated cells lining the mucosa. You can actually feel this on your own throat, and if you gently just run your fingers down the sides of your throat, you can feel where those cartilage rings are. So when we look at voice, we have false vocal cords that are going to be upper folds in the mucous membrane of the larynx. So if you were to just remove the head and look down the neck, the first thing you would see would be the false vocal cords. They don't actually produce any sound, but what they do allow you to do is hold your breath against them to build thoracic pressure. This is what allows you to be able to cough. Your true vocal cords will be below there, and they're going to be elastic ligaments that will vibrate to produce sound waves. When you increase the pressure, it will increase the volume of the sound. The pitch is controlled by the tension in the cords. The more taut, the higher the pitch. The vocal cords are thicker and longer in males, which is going to give them a deeper voice. If you develop some scar tissue on there, it will actually make the voice deeper. This is usually more noticeable in a female because at some point it goes from sounding like a female voice to a male voice, but it does occur in both sexes. So your trachea is the air pipe. This is going to have those cartilage rings that we looked at in this picture here, and the cilia that will help to move the mucus along that pathway. So when we look at the bronchial tree, here this middle picture shows the bronchial tree. You have the trachea in the center, and then it literally branches off like a tree. So the first branches will be the primary bronchi, then it will branch into the secondary, then into the tertiary, then to the bronchioles, and then the terminal bronchioles. So there is a slight change in the tissue as you move out, but they basically just branch off in order. When you look at this picture here, you'll notice that on the right side and the left side, one is oriented a little bit more vertically and one is oriented a little bit more horizontally. On the left side here, it is a little bit more horizontal to accommodate for where the heart is. So if a person were to aspirate something, it does have a greater chance of going down onto the right side just because it's a straighter shot. It doesn't mean that it can't go down onto the left side, just a greater likelihood of it going onto the right. When we go into the lungs themselves, the lung cavity is going to be lined with the parietal pleura. So that pleura is going to line the cavity that the lungs sit in. The visceral pleura is going to cover the lungs themselves. And the space between the parietal and visceral pleura is going to be the pleural cavity. That space should be airtight. When we look at the lungs, the bottom is considered the base, and the apex is the top. The hilus is where the bronchi enter the lungs. You'll notice that it is down a ways. It does not come in directly into the apex. So what that means is this air up here in the apex is going to have a little bit less turnover just because all of the tubes are aiming down. So with less turnover, that means if you inhale something toxic, it's going to be sitting in there a little bit longer. Consequently, it is the area where you're more likely to find lung cancers. The fissures are going to separate the lobes of the lungs. The lobes are just the different regions. You have 3 on the right, 2 on the left. The reason for having 2 on the left is to accommodate the space where the heart sits. The alveolar ducts are going to carry the air into the alveolar sacs. So they're a common opening to 2 or more of these alveoli. And you can see that in this picture here. The alveolar sacs are surrounded by a respiratory membrane to allow for gas exchange. The respiratory membrane is basically made up of simple squamous tissue. On one side of it is capillary, and on the other side is the alveolar sac. This is good for easy gas exchange because it does not have to go through a lot of layers. With a single layer, the gases can move through easily. The surfactant is a lubricant in the lungs. This is going to prevent the lungs from adhering to themselves. So they are a thin, moist tissue. Anything that's thin and moist like that, it could become sticky. So the lungs are the last organ system to really develop in a fetus. And the surfactant does not come in until about 36 weeks. So that's a concern with premature infants. We do have artificial surfactant that we can give them now that will help tremendously. Without the surfactant, when the lungs would collapse on themselves, the tissue would want to stick together and make it difficult to inflate. So with ventilation, inspiration is your inhale or breath in, and expiration is your exhale or breath out. We do use different muscles for this process. So quiet inspiration is what you're likely doing right now, where you're just sitting at rest. You're not needing any extra air. This will involve the diaphragm, which is a dome-shaped muscle that's going to sit underneath the lungs, and the external intercostals. So as the diaphragm pulls down, it's going to make the space that the lungs are in bigger. With the external intercostals, it's going to lift the ribs up and out to the side. So you can put your hands on your rib cage and take a deep breath in, and this will just really emphasize this so you can feel those intercostals expanding. When we do forced inspiration, we're going to involve a few different muscles here. This is going to be when you need to get some extra air in. First would be the sternocleidomastoid or SCM, and then the scalenes. Both of these are in the area of the upper shoulders where the shoulders meet the neck. What they're going to do is lift the rib cage up. The pectoralis minor is going to be more in the front, and this is going to help lift the rib cage out in front. So both of these are going to work to expand that cavity that the lungs are in. For quiet expiration, this is going to be a passive process. It's just the elastic recoil of the muscles going back to their resting position. Forced expiration, this would be if you want to push some additional air out. This will involve the internal intercostals, which is going to close down the rib cage. Also, the internal and external abdominal obliques and the rectus and transverse abdominis. This will compress the abdominal cavity. By compressing the abdominal cavity, it's going to push some of those organs up against the diaphragm to help displace some more of the air. During pregnancy, as the fetus grows, it also helps to push some of the organs up and displace some of the air, making it more difficult to get deep breaths in. So pressure changes will occur during ventilation. So here, this picture helps to show some of these things. The diaphragm is pulled down during inhalation. What this is going to do is increase the size of the air cavity. By increasing the size of the cavity, it's going to force it to pull air in to decrease that vacuum that would have been created. So your atmospheric pressure at sea level is 760 millimeters of mercury. When the diaphragm pulls down, that's going to drop a little bit. So different sources do give different numbers for this. In the notes here, it's showing it drop down to 756. So there's a 4 millimeters of mercury difference in there that is going to pull air in. When we go to exhale, the diaphragm is going to go back up. That's going to increase the pressure. So here it's showing the pressure going up to 762 millimeters of mercury. That's going to be used to push the air out. So this cycle will go back and forth. I'm not too concerned about you memorizing these numbers because most of the time you're probably not at sea level. So if you go up or down from sea level, your numbers are going to change a little bit. The key thing to know is during inspiration, there's a decrease in pressure that's going to pull the air in. During expiration, there's an increase in pressure that will push the air out. The spirogram is a tool that can be used to measure respiratory volumes. So the tidal volume is the volume of one resting breath. It is about 600 milliliters. There is a little bit of variation in this with a person's size. So down below here, we have some lung volumes that you can see. Here in the light blue, this little line, that's going to be your tidal volume. So you can see it's a really small amount on that chart. Your inspiratory reserve volume is the additional air that you could inhale after a normal inhalation. So when you're just sitting here after you've taken a normal breath in, this is the additional air you could forcefully choose to inhale. That's about 3,100 milliliters. Your expiratory reserve volume would be the forced exhale volume. So after you've taken your nice relaxed exhale, that would be the additional air that you could push out here. So you can see this amount down here in the light purple color. The residual volume is what's left over in the lungs after forced exhalation. So even after you have pushed all the air out you can, there's about 1,200 milliliters left sitting in the lungs that does not normally leave. Your inspiratory capacity, this is your inspiratory reserve and tidal volume. So if you've stopped after a nice passive exhale, that would be the full amount that you could inhale. So it includes your tidal volume plus the additional that you could inhale there. The functional residual capacity, if you're just sitting doing your quiet respiration right now, that's the amount that's sitting being unused in the lungs. It's the residual volume plus that expiratory reserve. Your vital capacity, this would be the maximum you could exhale if you took in a forced exhale. or took in a forced inhale. So imagine you're going to blow out birthday candles. You take in the biggest breath you can, and then all of that air that you can push out normally would be your vital capacity. So the total lung capacity is going to be the total volume the lungs can hold. And that comes out to be about 6 liters between the two lungs. So if you're looking to kind of get an idea, if you think of just the typical water bottle that you would get out of a vending machine, those will usually hold about a half a liter. So that will kind of let you visualize how much is 6 liters in the lungs. So with gas exchange, it's going to follow the gas laws that are used in chemistry and physics. The two main ones that we're concerned about here are Boyle's law and the law of partial pressures. What Boyle's law states is that pressure is equal to 1 over volume. What that equation means is the bigger you make the volume, the lower the pressure will be. So if your volume was a unit of 2, pressure is 1/2. If the volume went up to a unit of 4, pressure would go down to 1/4. So as you make the volume of the lungs bigger, the pressure will decrease. That's going to pull air in. The law of partial pressures states that the total pressure is the sum of all of the components. Pressure of component 1 plus 2 plus 3. So if our resting pressure at sea level is 760 millimeters of mercury, nitrogen is a little over 78%. So the pressure of nitrogen would be 597.4. Oxygen a little around 21%. That would come out to be 158.8. Pressure of water is 3. Pressure of carbon dioxide is 0.3. And the pressure of the miscellaneous other gases comes out to be 0.5. So what we know is when you have an equation like this, what you do to one side of the equation, you have to do to the other side of the equation. So if we go up in elevation and we decrease the total atmospheric pressure by 50%, we have to decrease each of these components by 50%. So imagine you go high into the mountains where you decrease the atmospheric pressure by 50%. You're going to have 50% of the nitrogen, 50% of the oxygen, 50% of the water, carbon dioxide, and other gases. What you will really feel is that difference of the decrease in oxygen. Likewise, if you were to go down, like go scuba diving, and you increase the pressure, you're going to increase the pressure of each of these things. So that's the reason why it isn't just regular atmospheric air that's in a diving tank. So when we look at blood flow, it's designed to carry the oxygenated blood to the tissues. When we go to transport oxygen, it is very reactive. So it can't travel around by itself. That's what hemoglobin comes in. So this HB here is an abbreviation for hemoglobin. In the lungs, you have hemoglobin and oxygen that are separate. And when it comes in to the bloodstream, it's going to bind. It binds reversibly. So when it gets to the tissues, it's going to reverse directions, and the hemoglobin is going to release the oxygen to go into the tissues. So we want to get more than just diffusion to add that oxygen to the tissues. So there's a few things that will actually help increase the amount of oxygen that goes into the tissues. One of them is carbon dioxide. As you increase the levels of carbon dioxide gas, it's going to increase the amount of oxygen that is released from the hemoglobin. Hemoglobin will release it more readily. This works out pretty well. As you are using your muscles more, they're going to produce more carbon dioxide. That will help get more oxygen into those working muscles. Acidity will also affect this. As you decrease the pH, becoming more acidic, it's going to cause oxygen to be released more readily. So the other thing that happens when you are using your muscles more is you can get to the point of producing lactic acid. That's going to decrease the pH, helping to get more oxygen into the muscles. And then temperature. As you increase the temperature, it will cause oxygen to be released more readily. So also, as you use a muscle more, it will get warmer, causing oxygen to be released more readily in there. These are really the key reasons why a person would want to warm up to really maximize their athletic performance is it's going to help make oxygen be released more readily into those muscles. Carbon monoxide is bad news. It's going to bind to hemoglobin 200 times more strongly than oxygen. Basically, once it goes on there, it does not have a reason to leave. It's going to take that hemoglobin out of commission. So it is an odorless, colorless, tasteless gas. You have no idea when you are breathing it. Fortunately, you can get carbon monoxide detectors that you can put in your house. A lot of times they come with a smoke detector, and it will detect it in the air. So you want to use caution burning anything where you burn hydrocarbons because they do produce that. Even a candle will release a little bit of carbon monoxide. So if you have something when the power goes out that it says to use in a well-ventilated area, that is not something you want to burn in your house. So occasionally you do see things on the news where power goes out and people bring in things like a barbecue to burn in the house or kerosene lanterns and die of carbon monoxide poisoning. So you've been warned, don't do that. It is odorless and colorless, and you would not even know that you were dying from that. So there also is a little bit of carbon monoxide in cigarette smoke, so that is not helping you out either in that situation. Carbon dioxide, on the other hand, can be transported different ways. It is not as reactive in the body. So it can be travel on hemoglobin as well. So again, we have that reversible reaction. But it can also be dissolved in the plasma, where when it gets to the lungs, it will come out of the plasma and be exhaled. It can travel on other amino acids other than hemoglobin, and it can travel as the bicarbonate ion to the lungs. So control of respiration. We have a respiratory control center that's in the medulla oblongata in the pons. In there is a medullary rhythmicity center that will establish the basic rhythm of breathing. It's got an inspiration and expiration area. So this is going to make sure that you stay breathing even when you're asleep. So we do have some cortical influences here where you can voluntarily alter breathing patterns. This allows you to avoid inhaling water or certain gases. You go into the honey bucket, you can decide to hold your breath if it smells really bad. But your voluntary control is going to be limited by the carbon dioxide and acid buildup. If you hold your breath too long, the body has a simple solution. You'll faint and you'll start breathing again. So that's something to keep in mind if you are in the stinky honey bucket. If you start feeling faint, you better start breathing. That's not really the place anybody wants to fall down. So controlling respiration is something that can be a technique that toddlers will use as well. They will decide that if they don't get their way, they're going to hold their breath. And really, if they hold their breath too long, they're going to faint, lose consciousness, and they're going to start breathing again. We have chemoreceptors that are in the medulla oblongata. They're going to respond to the carbon dioxide and acid levels in the cerebrospinal fluid. So they're going to be measuring those levels and letting the brain know, can we let this person have voluntary control here, or are they not able to handle this? Let's take it away from them. Other things can influence the respiratory system. Your limbic system, anticipation and anxiety. This will typically increase respiration. Mechanoreception. It's going to detect when there is exercise or activity and increase respiration. Temperature. So when we have an increase in temperature, it will increase the respiratory rate. Pain can influence this in different ways. Visceral pain, which would be organ pain, will cause a decrease in the respiratory rate. Sudden or severe pain will lead to brief apnea. So if you think about it, if you've hit your finger with a hammer, stubbed your toe, what happens is you take a quick breath and you briefly hold it in there. And then if you have prolonged somatic pain, so this would be like musculoskeletal pain. Maybe you're running a marathon, you're at mile 25, the muscles in the legs do not feel great in there. It's going to increase the respiratory rate. So even if you are walking at that point, your respiratory rate is going to be slightly elevated just due to your discomfort. So this can be a useful tool to try and see if somebody is in discomfort if they can't communicate with you. So you could use this with small children, somebody who is elderly, maybe who's being medicated and can't communicate, even with your pets. So the airway irritation, this can also influence respiration. So this allows you to alter your breathing pattern so you can cough or sneeze. And then we also have an inflation reflex. We have stretch receptors in the thorax that when they are overstretched, they'll actually work to inhibit inflammation. So in looking at this, you may go, well, okay, I still hurt. It's going to inhibit inflammation. It's not going to block it altogether. That's the idea. There is some actual physiology when you're in pain and you're being asked to take a deep breath. It's not that it's going to eliminate the pain, but it will help to inhibit the inflammation. Basically, you just have to keep in mind that the pain could be worse if you were not breathing. So that is the end of the section on the respiratory system.